So for now, I want to introduce Dr. Gary Stobbe, and he will bring Fallon Zollers with him as well as part of his presentation, right? Gary Stobbe is a board-certified neurologist, subspecializing in cognitive behavioral neurology. I think many of you know Gary. Dr. Stobbe is a clinical professor at the University of Washington with a dual appointment in the departments of neurology and psychology and behavioral sciences. He serves as medical director of the UW Adult Autism Clinic and principal investigator of the Adult Neurodevelopmental Wellness Project. He has so many things. He's the director of the Adult and Elders Program at the UCED, in addition to his over 30 years of clinical work. Dr. Stobbe is going to talk with us today about the ecodidactic teaching model, anew, and the work that he's been doing on the True Blood Project. Please help me welcome Gary and Fallon. Please welcome.
Thanks, Stacy. Yeah, I'm actually going to be introducing Fallon. She's going to be talking about the fun stuff that we're doing with the anew project. But I'm Gary Stobbe. Those of you that don't know me in the room, I am an adult neurologist by training, and I went into private practice in the 1990s and had the luck and privilege to have trained at UCLA at a time when some of the founders of behavioral interventions were working at UCLA, and some of the early studies of autism brains with MRI scans were coming out. I thought it was a neurological condition, a neurodevelopmental condition, and I went into private practice, and in the 1990s, this is pre-AOL time, folks, those who remember that, and I had a cardiologist friend who had a son with a pretty profound form of autism, and I was like, yeah, I find it very interesting. I'd love to meet them. I was trained by I had the luck of having a mentor at UCLA that taught me to, when I was doing coma evaluations in the ICU, to assume competence, assume that the person could understand you and treat them with respect. I took the same approach with kids, and they were coming up and sitting on my lap, and I was like, this is really fun. And parents were saying, well, they don't treat doctors this way because we don't treat them this way in our systems. And so I realized then that I had a love of healthcare delivery systems and trying to repair the inequities of service. And so this was a partnership, and my wife and I launched an independent nonprofit in 2003 that was open for about 6 years before I went back to the university in 2009. And I'm going to tell a story. Many of you that know me know this story, but I'd like to embarrass Bill Dussault, who's here in the room. So it was around 2003 or 2004 that I was launching this independent nonprofit, and we were out on having a cocktail, and I was whiteboarding on a napkin. That's how we kind of whiteboarded back then. And I was really frustrated about the whole system and how I was learning about these systems barriers. And what are we going to do? How are we going to fix this? And Bill kind of chuckled and laughed and was like, Gary, you're dealing with a situation that's going to take generations. This is not going to be solved in your lifetime. And that was really frustrating to hear. But I valued that advice, and I took it to heart and recognized that this is a journey we're on, and we're making progress. And I have several mentors, in addition to Bill, in the room. I have Katrina Davis, who represents all of the families that I've worked with over the years. I have Ivanova Smith, who represents all of the self-advocates over the years. And I now specialize in adult neurodevelopmental medicine. You might say, oh, I didn't know that was a field. And I was like, well, it's not. We're inventing that field. We're going to be the first program to have that field formally, if I have my way. It's an interdepartment program that involves neurology, psychiatry, rehab medicine, and pediatrics. We're going to be combining our adult autism clinic with our adult neurodevelopmental wellness project that Fallon is going to tell you about. And in the spirit of mentoring and recognizing that we cannot accomplish this in one lifetime, I'd like to welcome Fallon Zollers, who's going to talk to you about the Adult Neurodevelopmental Wellness Project. Stacy Dim, who I think 20 years ago was working in your office as a legal assistant, Bill, at the time. And Stacy, who is now leader and executive director of the ARC of Washington, partnered with Rep. Farivar sitting next to her, kind of found that I had this idea of bringing together an interdisciplinary team as a consult liaison team to help people that were stuck in the hospital. I couldn't get the funding in that time, but was thankful to get approached to work with folks stuck in the criminal legal system. And Fallon Zollers is our project manager. Fallon just completed her first year master's in public health at University of Washington and is doing an amazing job of leading our team. So without further ado, Fallon, come tell them about your work.
Okay, hope I can work this clicker, but I'm Fallon. I am the program operations manager for the Adult Neurodevelopmental Wellness Project. So first I want to talk a little bit about intellectual and developmental disability in the criminal legal system. So we know that adults with IDD have a high co-occurrence of mental illnesses, and that these contribute to an increased incidence of first responder calls, emergency room visits, hospitalizations, and unfortunately arrests. We do know that there are protective factors, that medical, educational, and social services and supports help reduce instances, but that these are often really difficult to access, especially in some of the underserved communities that we've talked about today. So successful diversion and recidivism reduction can be difficult because there's just a lack of appropriate, coordinated, and accessible services. A lot of times when folks come into these systems, there are maybe some options for them, but they don't really work for the folks who have intellectual and developmental disabilities. So born out of that sort of increasingly difficult problem, there have been some things that have happened at the state level that have created or allowed for the creation of our program. The first is the True Blood lawsuit, which most of you probably know about. But out of that, one of the great things that came out of that class action lawsuit, where individuals were having their rights violated by being held waiting for competency evaluations and restoration services. One of the awesome things that did come out of that is this settlement agreement, where the state settled with Disability Rights Washington to invest in both the competency system itself, but also diversion, recidivism reduction, and community services and supports for individuals who are coming into the criminal legal system who have challenges with competency or mental illness, substance use disorder, and what intellectual and developmental disabilities is a part of that. So that was in 2018. In 2023, the Washington State Legislature passed Senate Bill 5440, which really recognized this unmet need of a subset of True Blood class members. So those are individuals with traumatic brain injuries, with dementia, and with intellectual and developmental disabilities. So they were seeing that there is sort of this bottleneck or this difficulty moving them through services or keeping them out of the criminal legal system. We are grateful to the legislature for including our program as a part of that bill. So in 2024, we launched, and then we will report back to the state legislature in November of 2026. So just a little bit about IDD and the competency system. So all individuals have a constitutional right to understand the nature of the proceedings against them if they've been arrested. And they also have a constitutional right to participate in their own defense. So if an individual is found unable to do that, then they move through a sort of separate portion of the forensic system called competency. And almost 8,000 people were moved through the competency system in 2024. So what we do know is that intellectual and developmental disabilities are under-identified in this population because of all of the sort of systemic challenges. They've been arrested, they're sitting in a jail cell, we're not looking at their medical records, we're not talking to their families. And so we might not observe that disability, and it might not be possible for them to articulate that. But we do know that even the identified population is overrepresentative. So they make up between 5 and 10% of True Blood class members. So talk a little bit about the work that our team was given in Senate Bill 5440. So our project has 2 components, a retrospective report and a prospective pilot. The retrospective report is really focused on reviewing records, gathering data, and understanding who this subset of individuals are. And then the prospective pilot is to understand how interdisciplinary and comprehensive support can help individuals get back to their communities of choice. This goes into just a little bit more detail of that. So retrospectively, we're going to describe the population demographics. We really want to focus on identifying facilitators and barriers to community integration, and then analyze what are some of the more upstream protective and risk factors for having folks who have intellectual and developmental disabilities enter the criminal legal system. And then we have our pilot program, which provides interdisciplinary transitional services to 20 individuals. The goal is to have that done by 2026. We offer therapeutic, medical, and social work services. So we have a team of clinicians that work together with the care teams of the individuals that we serve. We have occupational therapy, speech and language pathology, applied behavioral analysis. We have Gary Stobie's our neurologist. We have psychologists and postdocs. We also have a psychiatric nurse practitioner. And perhaps the most core member of our team is our social worker, who really helps connect all of the medical and therapeutic services, but also the supports that individuals receive outside of that. Okay, so this is just a brief timeline of what we do and where we're headed. So we have half of year 1 and half of year 3 that ends up being 2 years, but really took a long time to get our data built, had our first participants. We now have 8 folks enrolled. We've begun our initial analysis of our retrospective data, although we are hoping to continue to expand our data share agreement with the state and continue to get more data. And then we are about midway through our mid-program evaluation, which has been really great, getting feedback from the participants in our program, their stakeholders, and just looking at how the pilot program is running. We'll hope to complete the pilot by June, the end of June of 2026, and then we will report back to the state in November of 2026. So just some things on where we're at and some of the stuff that we've learned with our pilot. We're happy to report that we are having some success moving folks out of some of the more restrictive environments that they're in. So that includes Western State Hospital. We've had folks discharged to supported living, which has been really wonderful. The thing I'm most proud of is that one of our first participants has never had stable housing in her adult life, and she has been successful in supported living for 5 months now, which is really special. Yeah. And we do see an increase in community engagement. We have folks who are getting connected with guardianship, other supports, and then an improvement in daily living skills, which has been wonderful. 100% of the staff and stakeholders that we surveyed have found that our team helps participants reach their goals, which is awesome because we are person-centered, we are strengths-based. Our goal is to help folks get what they say they need and not necessarily what others say they need. Sometimes we do see systemic challenges that still present significant barriers to community reintegration, which can be difficult, but working on identifying what those are so hopefully we can advocate for some of the reduction of those barriers. These are 2 pieces of feedback that we've received on our pilot that were meaningful to me that I wanted to share with you all. The first is from the parent of a participant who said that with our team, their participants' rights were able to stay on their table and that their concerns were able to be worked on when previously they felt that they had been ignored. And then the second is from an administrator that we work with, and want to really just highlight that the ANU team is able to sort of positively challenge some of these like entrenched systemic things that happen and work to really move towards a more person-centered and strengths-based clinical approach. Now I'll move to some of our initial retrospective findings and things that we're learning. So what we know is probably what you all know too, which is that these folks have complicated lives and complicated histories, and they have historically not received the services and supports that they need. So we have a really high rate of housing instability, so folks who do not have permanent supported living, folks who live in shelters or on the street. We see a really high rate of high school dropout. So about 40% of the IDD True Blood class has not graduated high school. That's compared to just 7% of Washington State more generally. We also see that they have low rates of employment and low rates of community connection. So really are not integrated into their communities even when they are not being institutionalized. We also know that they're complex, that they have high rates of substance use disorders, they have mental illness, and many of them are touching inpatient or emergency room services. They're touching like intensive medical care, but they're not receiving regular outpatient treatment. And then we know that support is limited and variable, and it can be a barrier or a facilitator. So if someone has really strong family advocacy, if they have a strong support network, that can help with keeping them out of the criminal legal system, help with getting them back to their communities, but that when those things are absent or when those things are ineffective, that they can be a real barrier. So I just want to highlight some of the ways that like services are really difficult to find. So Senate Bill 5440 did another wonderful thing where it requires the Developmental Disabilities Administration to take referrals from folks with IDD who've been found not competent and not restorable. However, getting through to services with DDA is still extremely difficult for this population. So you can see here that there were 116 referrals and 112 of them were accepted in the first 8 months of Senate Bill 5440. And then you can see here that only 2 individuals were found newly eligible for services. So there's still really significant problems. Being able to contact them, accessing them before they return back to whatever situation they were in previously, having no support for submitting the applications, not understanding what services are being offered. There are just so many things. A big issue is also just that like these folks come from complex and underserved communities, and so oftentimes they might not have the records, and the sort of burden of proof is on the individual, which means that their eligibility can often be denied. So I want to just talk a little bit before I end about what we know and what we need. So what we know is that individuals have not historically received the services and support that they should have. 3/4 of True Blood class members with intellectual and developmental disabilities have never received disability services. We also know that the data that we have is insufficient. It wasn't until 2023 and the passage of 5440 that disability or intellectual and developmental disability of any kind was really captured in the forensic system, which means that it's hard to see who this population is. We also know that these things are cyclical, and the only way to break these cycles is sustained and continued investment in this population. About half of the IDD True Blood class members have had competency evaluations before, and about half of them have had inpatient psychiatric stays. This means that they are touching these institutions multiple times, and they are not, like, we are not succeeding in helping them stabilize and return to their communities in a way that is long-term and meaningful. And then it is our belief that an interdisciplinary approach, and I really like that term, like intersystemic approach, is what will help support the folks. So we have the belief that medical, social, and community supports working together, sustaining that work over time is really what will help these folks. So I'll talk a little bit about next steps, and then Dr. Stobie will come back up and give you just a little bit of a conclusion. So we're hoping to continue and work to support these 20 individuals in our prospective pilot. We're going to do our epidemiologic review, so really understanding the population level characteristics of these folks and the services that they've received. And then we hope to expand from there. So continuing to expand the pilot, do more research, advocacy, and clinical training, and then integrate these adult neurodevelopmental services into existing healthcare delivery. So, thank you.
So just to conclude, I think that when you see the presentation, I think one of the things you see those large numbers of folks that are stuck in the system. You see the relatively small number of folks that we've been able to help so far, and you see that interdisciplinary team, which those of us that do this work, it has become kind of a no-brainer that it takes this interdisciplinary approach, but it's not easy. It's expensive. When you think about bringing all of those providers together. Now, from my perspective, though, the good thing is we are less expensive than the alternative. So, and the outcomes are a lot better than the alternative of being stuck in jail or stuck in a mental health institution. The other thing, though, is that we don't have enough of us, right? So I mentioned this field of neurodevelopmental medicine is basically we're trying to invent it. And so we are going to need everyone's help in this room to be able to build this program at the University of Washington. We need the continued support of the program that Jim directs with the Include Collaborative on how we can take champions that are already providers in the community that want to connect to give them the support and guidance so that they can develop their practices all across Washington State. And we could basically help support folks to reach this ability in a sooner time and quicker to get the services to those that need those services now. So just very happy. Again, thank you for inviting us to present this. We're very excited about the data that we'll be bringing over the next 12 months. It's been pretty amazing to be able to get access to some of these records and to really get a better understanding and not just admire the problem, but really come up with solutions. So, thank you.